waiting too long. I'm Keith Frederick. I'm the representative from the 121st District, live in Rollins.
Can you speak up or move the microphone?
Sure, thanks. And I want to thank the committee and the chairman for allowing me to present this bill today, House Bill 1842. I'll try to be succinct, because I do have some folks that have traveled to testify. As you know, there is suboptimal access to health care in some of our rural and some urban areas of our state, and the trends don't look good. There are many reasons for this, and most of them are not very easy to solve. The proposal I bring to you today, however, is an idea that can improve access to health care in the areas of our state that are most in need. When a physician finishes medical school, generally they apply for a residency program. And in order to do that, they interview around a bunch of different hospitals in the specialty that they want to go into, and the hospitals interview multiple candidates for the residency positions. And then to facilitate this matching up of the individual that wants the residency and the hospital that wants the doctors to staff it, there's a match. And it's conducted by a group called the National Resident Match Program. A certain number of doctors don't match, and there's a supplemental, used to call it a scramble, now they call it a supplemental opportunity for matching. But anyway, at the end of the day, there are some positions that simply don't match. And they generally sit out a year. Now, this may be docs that maybe they want to be a pediatric cardiologist or whatever, and they just really have hitched their wagon to that star and they're not taking anything else. But there are a number of reasons. They could do research for a year. There's many reasons why they may not match. I want to point out that it's not doctors that are somehow deficient. They've passed step 1 and step 2 of the boards, which are extraordinarily difficult, and they graduated from medical school. So my proposal actually comes from an idea from a gentleman you'll hear from shortly, that such physicians be allowed to come to Missouri to practice under a collaborative practice agreement with a licensed physician. So these individuals would be called assistant physicians under this proposal. They would need to be a resident of the U.S. or a citizen here legally. They would need to have passed steps 1 and step 2, their board exams, and graduated from a medical school, the same medical school as described in the statutes now for licensure in the state. And that they have not yet begun a residency or matched for the residency. You know, this, I think, is also a topic for us to discuss, whether we should limit it to those who have not started a residency. It may be that it would be wise to allow that as well, but that's further into the weeds. Currently, a doctor can sit for Part 3 of their examination and become a licensed physician after 1 year of postgraduate training. Not many do this, but it is a possibility. So without that extra year of training after you graduate from medical school, it is this proposal to allow them to practice not independently, but in collaboration with a supervising physician, just like our PAs and NPs do. We would propose that this would take place within 18 months of passing step 2. That, I think, is a topic for this committee and the legislature to consider about the length of time that's appropriate. Currently, if a doctor has been out of practice for more than 2 years, the Florida Healing Arts requires some remedial training. They would have to begin practice within 6 months of licensing as an assistant physician, and they couldn't have more than a 6-month lapse between collaborative agreements with a supervising doctor. They would have to go to an underserved area, either an urban underserved or a rural underserved area, or to the geographic region of a pilot program that I'm proposing this year for Medicaid reform. So this is different than what our current NP and PAs have. We would require them to go to a rural or urban underserved area. That's not the case with our current physician extenders. They would only be able to practice in primary care, because that's what the need is. We need primary care in our underserved areas. That's also different from the current statutes for PAs and NPs. There is also language that describes the development and implementation of proficiency benchmarks and periodic skills assessments. It's been my position for some time that we should try to improve the collaborative arrangement between physicians and so-called physician extenders, and to try to result in increasing knowledge, increasing capabilities as time goes on in the relationship. Now, this also requires name badges be displayed when their patients are seeing, their practitioner or PA or an MP, for transparency for patients. Now, I believe that there is also value in developing one set of collaborative practice requirements for all three sets of individuals, and that is best done by the Board of Healing Arts in consultation with the Board of Nursing, and that's the current language in the bill. It's not my desire, however, to create strife with my colleagues in the nursing profession, the advanced practice registered nurses. While I believe this arrangement would foster increased collaboration and an inclusion of the APRNs in the educational and benchmarking provision would enhance the physician-nurse relationship, if it is the view of the nursing board and the advanced practice registered nurses that this is not desirable, then I think these new individuals, the assistant physicians, could be placed under the Board of Healing Arts, and regulations specifically for them can, I'm sure, be developed. So I think I'll stop at this point. I have a few other remarks, but it's gone a little longer than I thought it would, so I think I'll stop to allow others to question and provide this.
All right, thank you. I want to say, before we begin, I want to thank you for, I think, is a new idea, coming out with a bold new idea, and sometimes with challenges that we face. It's refreshing to see ideas, and so it's good. I welcome any discussion, and I think that because it's a new idea, it's something that we need to thoroughly examine. And so, as committee members, I'm asking for your help and participation as we examine this bill and make sure that something that's this new, that we give it a very good look over. So, with that, are there any questions for the witness? Representative Lichtenegger.
I would like to inquire.
Proceed.
Thank you. I have a couple of questions, and I like the idea. I think we've talked about this, but I do have a couple of ideas on this, and so we're doing another provider, but it's in specific areas of the state. Is that correct?
It would be in areas that are underserved, either rural, underserved, or urban.
Okay, right now, like an APRN, for instance, they can only have a collaborative practice with 3 physicians. Is that, or the physician only?
Yeah.
Okay, I'm sorry, I meant to say that the other way around.
Yeah.
So sometimes that physician may not be necessarily in an area of need, and their APRNs may not be in that area. Is it possible to, instead of cutting you short as to how many you can have, if this person is going to an area of need, could you have 4? I mean, would that be a problem?
It seems to me that managing and having proper interaction with 4 individuals, I believe it's kind of pushing the envelope a little bit to do 3.
Yeah, but aren't you going to lose some of your nurses? I mean, they do different things than what doctors do.
Yes, but I believe that we've crafted this with particular attention to the workforce that we have now, in that we have underserved areas specifically because the current providers don't locate there. So the requirement would be that these new providers would have to locate in an area where there's insufficient access to health care present.
But some of our APRNs are in those areas. Is that not true? Would they be working with an APRN? Would they be working? I'm just trying to understand.
Yes. Well, I think the point that I'm sort of sensitive to is the number of my colleagues, our colleagues, that we've heard over the last several years that report that in their county they just have insufficient access to health care. And so by requiring this new group of folks to go out to an area that's underserved, I mean, that's the best way I could come up with to try to provide more workforce in the areas that are currently not sufficiently served.
Okay, and you say that they would be having consultations with you, and I think the nursing law says jointly promulgate. Is that the same thing? Is it just a different language?
Oh, you're not talking about consultation between the assistant physician and the physician. You're talking about developing the rules and regs would be what I touched on in the beginning. And I know this is a controversial area, and I'm certainly not ducking in this. I'm looking for the will of the committee and the will of the body.
Yeah, I'm just kind of...
But the way it's structured now is that the proposal is that the regulations for all 3 of these groups, I think there's some value in having a uniform set of rules that applies to all 3 of these so-called physician extenders. And what I've included in this bill is that there be one set of collaborative practice standards and that all three of these individuals, these types of individuals come under that, and that the rules are developed by the Board of Healing Arts in consultation with the Board of Nursing. Now, I understand that that may not be a popular thing, and so I'm not big in on that. If it turns out that the best way to do it is to have the nurses continue to be licensed by and under the nursing board, and then bring this new group of people under the Board of Healing Arts, if that's the will of this body in the legislature, it's...
Okay. And I have one more question, Mr. Chair. What exactly is, with a medical student, when do they do their internship?
The year following graduation from medical school.
Okay, so these are people who have done their medical school.